If you would like to claim continuing education credit for attending today's session, register with CDC's Training and Continuing Education online system and search the course number on the screen for the Hospital Sepsis Program Core Elements webinar series.
Good afternoon, everyone, and thank you for joining us for the first installment of our Hospital Sepsis Program Core Elements webinar series. Before we get started today, I have 3 disclosure slides to show related to the CE that's being offered through CDC's Training and Continuing Education online system. We will advance through them slowly to allow you time to read. The first is the following accreditation statement. This webinar is accredited for CME, CNE, CEU, CHES, MCES, CPE, and CPH. I will now share with you the following disclosure statement from CDC. Please give it a minute to read at your leisure. I will now share the following joint accreditation statement for pharmacy education. Again, please take a minute. Thank you for your attention to those statements. This 5-part series will explore the nuances and details of the new Hospital Sepsis Program Core Elements. These core elements will help U.S. hospitals implement, monitor, and optimize institutional sepsis programs and improve sepsis outcomes. They complement the existing sepsis guidelines and help facilitate the implementation of guideline-recommended care practices at a wide variety of hospitals and healthcare systems in the United States. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. As you know, anyone can get an infection, and almost any infection can lead to sepsis. Sepsis is the body's extreme response to an infection. CDC estimates that about 1.7 million adults in the United States develop sepsis each year, and at least 350,000 of them die each year because of it. The key to improving sepsis outcomes is early recognition and prompt treatment, requiring everyone's vigilance. We've put together this in-depth series to look closely at important elements that facilities can use to build robust sepsis programs. Each 1-hour webinar will discuss key features of effective sepsis programs and include examples from CDC partners sharing strategies, real-life examples, and best practices for successfully implementing one or more sepsis program core elements. Today is the first of 5 webinars, and we will focus on an introduction to the Hospital Sepsis Program core elements and the first core element of leadership commitment. We will be hearing first from sepsis experts who will outline what these core elements are and the role a committed leader plays in implementing necessary human, financial, and information technology elements in making a successful sepsis program. Then we will hear from 2 more experts who will bring examples of successful implementation of the leadership core element at their institution. In addition, we have gathered questions from you when you registered, and we will ask the experts to address some of these today. I'm honored to introduce our first 2 sepsis experts. Dr. Ray Dantes is a medical advisor in the Division of Healthcare Quality Promotion at CDC and an assistant professor of medicine at Emory University Hospital, where he practices hospital medicine. Dr. Dantes provides technical assistance to CDC sepsis epidemiology studies and educational efforts, and partners with other leaders in sepsis to advance the field of sepsis surveillance. Dr. Hallie Prescott is an associate professor in pulmonary and critical care medicine at the University of Michigan and a staff physician at the Ann Arbor Veterans Affairs Healthcare System. She works clinically in the medical intensive care unit and outpatient pulmonary clinic. She is an internationally recognized expert in sepsis management and outcomes. She serves as the co-chair of the Surviving Sepsis Campaign Guidelines and physician lead for the Michigan Hospital Medicine Safety Consortium's Sepsis Initiative. Let's hear from Dr. Dantes and Dr. Prescott on what the Hospital Sepsis Program core elements are, what is needed to fully develop a sepsis program, and how the leadership core element influences a sepsis program's success.
Thank you. Pause here for just a few seconds for our disclosures. Next slide, please. The hospital sepsis core elements are modeled after a similar successful initiative in antibiotic stewardship. In 2014, the CDC released the core elements for hospital antibiotic stewardship programs. This is a guide for structuring a program that monitors and encourages appropriate antibiotic use. It doesn't tell you which antibiotics should be prescribed for which patient, but zooms out from the bedside and provides guidance for how you run a quality improvement program that continually improves this aspect of care. Next slide, please. We have used the National Healthcare Safety Network annual survey to monitor uptake of these stewardship core elements. Now, as you can see, in 2014, about 41% of hospitals achieved all 7 core elements, increasing each year through 2021, when 94% of hospitals have achieved the 7 core elements. Next slide. Early this year, we used this same NHSN survey to ask about baseline practices among sepsis programs in US hospitals. Those results were recently published in the CDC's MMWR journal. Next slide. This graphic highlights some of those key findings. 73% of US hospitals have a sepsis committee. 55% of hospitals provide dedicated time for sepsis program leaders. And also about 55% of sepsis committees involve antibiotic stewardship programs. Next slide, please. With this background, the purpose of the hospital sepsis program core elements is to provide guidance for hospitals to better monitor and optimize their sepsis programs. So this includes an emphasis on that leadership support, personnel resources, quality improvement tools, and implementation science. Importantly, the core elements complement those existing sepsis guidelines and help facilitate their implementation of recommended practices. Furthermore, we also emphasize the care of sepsis and management throughout the hospitalization and recovery. Our intended audience is US hospitals and hospital systems, and we think these core elements are applicable regardless of the hospital type or the population that they serve. I would now like to introduce and thank our development partners, Dr. Hallie Prescott from the University of Michigan and her team from the Michigan Hospital Medicine Safety Consortium. Dr. Prescott will discuss the development process and introduce the core elements. Thank you.
Great, thanks so much. In terms of the development process, there was a number of things that we considered as we developed the core elements. First, we reviewed the existing literature on sepsis quality improvement, but also broader quality improvement and other conditions that would be pertinent to sepsis. We got input from frontline clinicians, and we did this primarily through the Michigan Hospital Medicine Safety Consortium, which is a quality improvement collaborative of 69 hospitals in Michigan, which includes diverse hospitals, including large academic medical centers, as well as small critical access hospitals in the rural Upper Peninsula. So this was a unique way to get input from really a diversity of hospitals to make sure that this guidance is applicable to the many different types of hospitals that we have throughout the US. After we had a good working draft of the core elements, we then sought broad stakeholder feedback. We met with patient advocacy groups, federal agencies, professional societies, the American Hospital Association. We took that feedback and then we further revised the core elements prior to releasing them. Next slide. So the core elements were released in August and included a number of different documents. The first, the core elements guidance, provides a sort of broad guidance on running a hospital sepsis program to help hospitals do an assessment of their program. We include this sepsis program assessment tool, which hospitals can use to go through the different recommendations and assess where their program is. This will allow hospitals to focus on kind of the next steps to advancing their programs. We also have a getting started section for hospitals that may be just starting a hospital sepsis program for the first time. So really these guidances are meant to be flexible for hospitals that have been, had a mature program in place for many years. This provides next steps to how to further refine, and then for hospitals just getting started. And on the far right, we have an overview graphic, which goes through the 7 different core elements. Next slide. This figure as well goes through the 7 core elements, which I'll summarize briefly, and then we'll go into more detail about the hospital leadership commitment. The hospital leadership commitment talks about the importance of engaging the hospital leadership into the sepsis program. Accountability talks about having a defined leader or co-leaders for the hospital sepsis program, as well as setting realistic but stretch goals for your program and holding yourself and your hospital accountable and tracking progress towards meeting those goals. Multi-professional expertise talks about the sort of broad number of stakeholders that it's important to engage in these programs. Sepsis is something that can happen to really any patient anywhere in the hospital, and so it's important to have engagement across different disciplines and specialties. The next is action, and this talks about the structures and processes that hospitals can do to facilitate the implementation of evidence-based practices for sepsis. So this talks about things like order sets or hospital care pathways for sepsis, how to develop those, and how to ensure that they are being used by providers in your hospital. Tracking reports, it talks about monitoring what is happening in your hospital in terms of sepsis epidemiology, sepsis management, and sepsis outcomes. Reporting goes hand in hand with that and talks about then giving that information back to important stakeholders at the units, at the hospital director level, so that this information can go to continuously improving sepsis management and outcomes. And then finally, the education core element talks about the importance of broadly educating healthcare staff, patients, caregivers, families, so that everybody is aware of sepsis and improving evidence-based management of sepsis. Next slide. So we'll now go into more detail on that first core element, which is leadership commitment. For each of the core elements, we provide a number of concrete examples, and those have been prioritized. So priority examples, the most important examples, and then additional examples. So priority examples for leadership commitment include providing sepsis program leaders with sufficient dedicated time to manage the program and participate in performance evaluation and improvement activities. So essentially saying that their leadership's role in that sepsis program is part of their sort of job description, and they have dedicated time to carrying out those activities. The next is providing resources, things like data analytics, information technology support to operate the program effectively, ensuring that relevant staff from key support departments and groups have sufficient time to contribute to sepsis activities, appointing a senior leader to serve as an executive sponsor for the sepsis program to meet with that program and ensure that the program has the resources and support to accomplish that mission. Examples of senior leaders that could serve in that role include chief clinical officer, chief medical officer, or chief nursing officer. And then finally, communicating to the hospital staff that sepsis is an institutional priority. Next slide. Additional examples to show leadership commitment include communicating how the hospital is addressing sepsis, both to staff and to patients and families, having regular meetings between the leaders of the sepsis program to assess the resources needed to accomplish the hospital's goal for sepsis activities and outcomes, integrating sepsis activities into other quality improvement and patient safety efforts, such as emergency department triage, antimicrobial stewardship, transitions of care, and the CMS SEP1 reporting, and tying incentives to achievement of targets for sepsis care and/or outcomes, essentially incentivizing hospital staff to work towards those goals. Additional examples including sepsis program-related duties in job description for program leaders and key support staff, supporting the training and education for program leaders and key support staff, supporting internal training and education, and then supporting participation in regional, national, and international sepsis quality improvement collaboratives and initiatives. So these are concrete examples, again, that hospitals can look at in that self-assessment tool to say, are we doing these things? Are there important things that we're not doing that we could be doing to improve our institutional response to sepsis? final slide we have to share is that uptake of the sepsis core elements will be tracked via the annual NHSN survey, just as they were for the antimicrobial stewardship. There were 4 questions that were included in the NHSN survey earlier this year, and additional questions will be added to the next survey, which will go out in January 2024, to evaluate uptake of the complete core elements.
Well, thank you, Dr. Dantes and Dr. Prescott, for introducing us to the sepsis core elements and working through the benefits and necessity of having committed facility leaders. I'm excited to see how this might play out in the real world. And we are joined today by Dr. Jesse King and Ms. Patricia Poza, both from the University of Michigan. I will introduce them both, and then we'll hear what they have to say about this topic. Dr. King is an assistant professor of hospital medicine at the and the medical director of sepsis initiatives in the quality department at Michigan Medicine. She became involved in quality work accidentally when asked to attend some meetings and share some opinions from a hospitalist perspective around work being done in the emergency department involving sepsis recognition. 8 years later, she finds herself leading the sepsis program, with improvement work being done following the entire scope of the septic patient's experience, from initial recognition of sepsis to post-hospitalization follow-up and reduction in readmissions. Ms. Poza is the Quality and Patient Safety Program Manager for the adult hospitals at Michigan Medicine. In her role, she's responsible for the development, measurement, and sustainability of the adult hospital's quality and patient safety program. Pat has been involved in many quality and patient programs over the years. She has been faculty for multiple state and national clinical collaboratives, including the Surviving Sepsis Campaign Phase 4 Collaborative. She serves on the advisory board of Sepsis Alliance and lectures and consults nationally on sepsis and various critical care, patient safety, and quality topics. Dr. King and Ms. Poza will share how the leadership commitment element was operationalized at University of Michigan Health, including making sepsis an organizational priority and getting the appropriate resources to move from a sepsis quality improvement project to a full sepsis program.
Well, thanks so much. And I'm going to start us off just a little bit about University of Michigan Health. We are an academic medical center located in Ann Arbor, Michigan. We have about 1,043 beds with over 15,000 staff and a beautiful campus. Go ahead to the next slide. So at Michigan, like other hospitals, we had focused on improving our sepsis care with multiple quality improvement projects going on. I had been involved at prior organizations setting up sepsis programs, and I knew that we were missing some of the foundational pieces to improve our sepsis outcomes. And that's the leadership commitment that Hallie just talked about, that sepsis needs to be managed early and aggressively, and it needs to be an organizational priority. So we started with creating the why and met with executive leadership to promote and ask for sepsis to be a priority for the organization. We shared our performance and how it matched up with other academic medical centers and hospitals, and how our current performance could impact the organization as well as our patients. At Michigan Medicine, at that point in time, our average compliance with the CMS SEP1 bundle was 37%. And we continue to be, well, now we're above 50% compliance, but we continue to be around 50% compliance. National average, 60%, with top decile greater than 80%. And you can get this information on Hospital Compare. We also looked at our mortality index, and it was 1.22. And so that's a observed versus expected. And so greater than 1 is not where you want to be. And we were ranked 15th out of 20 hospitals that were in the top 20 performing hospitals in the U.S. News and World Report related to sepsis mortality. And that's not where we wanted to be. And in 2019, sepsis was not an organizational priority. We had quality improvement teams in the emergency department and inpatient, as well as in transitions between inpatient and outpatient to help with early identification and timely interventions. But it wasn't enough. So our first step was to, so you can go on to the next slide, was to make sepsis an organizational priority. So we gathered our data with included the additional information that I shared on the previous slide. And it was really important to show the links between how sepsis was impacting other indicators the hospital was focusing on. So why should the executives worry about this? So we made the case outlining that sepsis diagnosis was our highest volume of admitting diagnosis after live births. Sepsis was the #1 cause of mortality at Michigan Medicine. And our mortality performance, we know, are part of many programs that the hospital cares about, value-based purchasing, Leapfrog, and CMS star rating. Sepsis is also our leading DRG for readmission, and they had long lengths of stay. And we know with our data that when we provided the SEP1 bundle or the evidence-based practice appropriately, both mortality and length of stay were decreased. So in presenting all of that information, we successfully were able to have sepsis be an organizational priority for the next fiscal year, and it continues to be. We chose first to have our bundle performance be the focus, and so you can see here we outlined that we wanted our bundle performance to be greater than 55%. When something's a priority, we know it gets more focused, it potentially gets more appropriate resources to support it, and leaders will be held accountable to reach those established goals. It also fit well into our organizational priority of becoming a high reliable organization. And as a high reliable organization, our goal is to reliably provide evidence-based sepsis care to all patients with sepsis. Next step was to get an executive sponsor. In the quality world, it's become clear to improve the potential of success, you need an executive sponsor for projects and programs. This was demonstrated through multiple national IHI initiatives, as well as here in Michigan through the Michigan Keystone work. That executive sponsor increases stakeholder engagement, reduces resistance, helps overcome barriers, and improves the overall program outcomes. And as part of our journey in HRO, as we made requests to executive teams, et cetera, we needed to place those requests into an SBAR, and you can see that displayed on the right side of the screen. And it outlined what our situation was, which is similar to the information, the why, as well as then what's the background and our assessment of where we're at, as well as our ask or our recommendation. And in the recommendation, it outlines the role of the executive sponsor. So be a resource to the sepsis committee and sepsis coordinators, serve as a link to senior management and the strategic aims of the organization, provide resources and overcome barriers on behalf of the team, and provide accountability for the teams and review the team's progress on a regular basis. At the time, we also were requesting a sepsis coordinator, but if you look at the timing, we had entered COVID. And so we had some delays, and we had to economically recover from the loss of revenue during COVID. So we were not able to, at that point in time, to get a sepsis coordinator. But in the organization, in the adult hospitals, it continued. Sepsis mortality was added as a priority, as along with the SEP1 performance, and it became an enterprise priority as well. So beyond just the adult hospitals. So go ahead to the next slide. The third step was to create that sepsis program. Moving from quality improvement projects to a program and ensuring we had the necessary resources. So we know that sepsis is not going away. It's not time limited like quality improvement programs often are. And we looked at other successful clinical programs like stroke and trauma and modeled after that. So go on to the next slide. So why did we need a sepsis program? This was the messaging to our leadership. Sorry, lights went out. Sepsis is our highest volume DRG. Sepsis is the largest driver of inpatient mortality. Observed sepsis mortality, length of stay, and readmission rates are above the expected rates, so our ODEs were greater than 1. In using our own data, our risk-adjusted data, it supported that bundle compliance reduced both mortality and length of stay. We had no clear defined clinical owners or operational owners of sepsis care. We knew in our organization sepsis recognition was poor. We were not treating sepsis as the medical emergency that it is, and the general knowledge of the sepsis bundle was poor. So again, we put an SBAR together to request the different components of a sepsis program, and it was beyond just the sepsis coordinator that we were requesting right during COVID. So the data we supplied, you can see here identified on the screen, looking at if we were compliant with SEP 1 or non-compliant, what was the difference in outcomes of interest, length of stay, ICU length of stay, and mortality rate. And you can see, I'll highlight that our length of stay was about 5 days less when we were compliant with our sepsis bundle, the evidence-based care. And you can also see ICU mortality was, or length of stay was less, as well as overall hospital mortality. So we partnered with finance to create a return on investment. Important to be able to do that. Why am I going to give you more positions? What is it going to get for me? I mean, that's the language that in organizations we need to speak. And so we did a pretty conservative estimate, and the outcome of interest that we used for the ROI was length of stay. So we looked at severe sepsis and septic shock populations for over 3 years, and compared to the length of stay when they were compliant with not compliant, as you can see on the graph, and the compliant patients averaged a length of stay of 5.2 days less than the non-compliance. And then we defined the variable cost per patient, a very conservative variable cost, and multiplied that by the number of encounters by the variable cost per day to come up with the dollars saved if we reduced length of stay by 1 day, by 2 days, or decreased it to the length of stay that we achieved when we were SEP 1 compliant. I'm going to turn it over now to Dr. King, and she's going to outline the components of the program and the requests that we made, as well as the sepsis program structure.
Yeah, so now that we had a dollar amounts that as play money to work with, we thought about how do we spend that money? How do we refocus that money into really improving our care? And so we thought about, the size of our institution. We thought about the number of patients that are presenting to sepsis to our emergency room versus developing sepsis inpatient. And also acknowledge that, attached to the adult building is this lovely pediatric hospital, as well as women's hospital where, sepsis was occurring as well, and with associated morbid consequences. And so we thought about, okay, who do we need? Who do we need to help improve and maintain and sustain that improvement? So when we thought about staff, I'm going to start there. We really thought about, okay, we originally asked, or were considering asking for 1 sepsis coordinator. We have way too many sepsis patients in our institution for 1 coordinator to do the job. So we actually divided that job into 3. And we located these coordinators geographically. So we have 1 coordinator that's dedicated to our adult emergency room. We have another coordinator who's dedicated to the adult inpatient hospitals across the institution. And then we have a 3rd coordinator that's dedicated to pediatrics and women's hospital. Along with those 3 sepsis coordinators, we needed somebody full-time to kind of keep tabs on everything that was going on. So we developed a position called the sepsis process lead. And this person works along with the sepsis coordinators and has, a sort of an overall picture of what's going on across the institution around sepsis initiatives. We recognize that our computer programs are essential to our functioning in the hospital. And and we can make no improvements without somebody in the background fixing the computer to do what we want it to do. And so we actually hired a sepsis, we call it a MyChart builder. MyChart is the University of Michigan's version of Epic, who has 100% dedicated effort to building all of the elements that we see as necessary to run in the background in terms of alert systems, as well as to build things like order sets and smooth the transition from emergency room to inpatient. So we have dedicated effort to our computer programming folks. We also asked for a little bit of an administrative assistant role as well. Now, recognizing that these sepsis coordinators cannot do their job without what we call sepsis champions, or physicians who are paired with the coordinators in order to provide the expertise related to that specific area. So we have dedicated effort given to 4 physicians. One is the medical director, who is partners with the sepsis process lead as somebody who kind of keeps tabs on what's going on across the institution with regards to sepsis initiatives. And then we have dedicated physician champions in MOT, which is our pediatrics area, in OB for our women and children's or women's hospital. And then in the ED, the ED sepsis champion has proven to be crucial in moving our sepsis initiatives forward. We also included unfunded positions who or positions that already existed within the hospital institution, and asked for a portion of their effort be dedicated to our sepsis program. So we have both the quality and safety officers for UHCVC, as well as the Women and Children's Hospital, with a portion of their effort to be focused, as well as a clinical quality administrator. And then what is also key is someone to help keep track of all this data. So we have institutional support. So these are, again, positions that already exist within the institution, for whom a portion of their time is dedicated to analyzing and summarizing sepsis data from across the institution. So this is what we found as sort of key people that needed to be involved in order to keep track of what's going on where across the entire institution. Next slide. And where do these people sit? So unfortunately, with an institution as large as University of Michigan and physical separate buildings and separate hospitals, we think about, we are a team that exists across the institution, and through, where these building walls do not form real barriers. So the sepsis coordinator for Women and Children's, for example, indirectly reports to the Women and Children's Quality and Safety Administrator. Within the main hospital, the adult ED and inpatient sepsis coordinators report indirectly up to the adult hospital Quality and Safety Administrator. And within that, the pediatrics and adult champions also sit within those silos. We also have a quality department, and within that quality department, the sepsis program sits within the quality department. So all of our direct reporting goes up through the quality department, and ultimately up through hospital administration, and we report, essentially to the board. And so, what does this look like on a practical basis? So our adult sepsis team and our pediatric sepsis teams work literally side by side. They share an office in order to collaborate. And we have connections to and have sought out the expertise of various groups across the institution. So that includes the Office of Patient Experience, right? The Clinical Intelligence Committee. How do we make sure that our alerts are functioning appropriately? The Health System Command Center, and then with outside organizations that support quality and safety, such as the Michigan Hospital Safety Consortium. We have connections with all of these groups, and we sort of see ourselves as the synthesizers of the information And we use that to develop our quality initiatives in order to improve our sepsis care. We have monthly meetings with the Sepsis Executive Committee, and that includes surgical leadership, medicine leadership, as well as the chief medical officer. We meet with them on a monthly basis, providing updates with regards to data, new initiatives, as well as discuss barriers that we are encountering to moving our initiatives forward. Their support has been invaluable as we hit roadblocks, as inevitably they have a way around or through or over said roadblocks. We also have an advisory committee that we call ISOM, which is Improving Sepsis Outcomes at Michigan Medicine. And these are key stakeholders and leadership across the institution from varying departments, including people who chair phlebotomy and who chair radiology. And so we have quarterly meetings with the ISOM group, where again, we are able to provide updates and bring barriers and see our way around and through and over those barriers. And as I said, ultimately, we report up to the Institutional Clinical Quality Council and through them to the Quality Committee of the Board of the hospital. So what has the leadership commitment meant to us? We've really developed over the last year or so support from the hospital and health system leadership, and the chief medical officer and chief nursing officers have become key colleagues and collaborators in this work. We were able to set sepsis performance as a hospital priority and appoint a senior administrator to serve as the executive sponsor for the program to ensure that we have the resources and support we need. We've created a sepsis program with these resources to accomplish those established goals, including sepsis program leaders and physicians with dedicated time to manage the sepsis program and to participate in sepsis-related performance evaluation and improvement activities. And then we've been provided the resources and support that we need to operate the program effectively, including data analytics and information technology support. As a result of all of these recommendations over the past year or so, we've seen significant improvement in our sepsis performance, particularly in the emergency room. And while we still have lots of opportunities, I believe we have the right structure and support to continue our work.
Thank you for providing such a robust background on the sepsis core elements and the need to have leadership on board for a successful sepsis program. I'd like to start the conversational portion of this event with a question from one of the participants watching today. Dr. Dantes, I'll ask you to consider this first, and then if others would like to jump in. How do I make the argument to our hospital administration that investment in the sepsis program will provide a return on investment?
Thank you. Well, I think you just heard a really good argument for that from Pat and Dr. King here. I think one of the things that they highlighted that I think a lot of people now I'm wearing my Emory Healthcare hat where I practice, that are coming to terms with is that Step 1 compliance is moving into from pay for reporting into pay for performance. And so now there are potential financial penalties, based on your Step 1 performance. And I think that can be a very timely way to justify and justify that return on investment. I'll open it up here to our other experts here to talk a little bit more about those specifics.
I think in our hospital, as Pat highlighted, we literally calculated the savings gained in hospital days by improving our performance. And it was, the average cost of the hospital day is X amount, and by reducing for 1,400 severe sepsis and septic shock patients a year, reducing hospital stay by 1 day resulted in this amount of savings. And it was literally, we had an actual dollar amount to bring to them, which I think was extremely valuable in making our argument.
And to tag on to that, the FTEs that we requested, based on reducing length of stay by 1 day and the cost savings from that, we would see our return on investment within 12 months.
Wow.
So it was pretty significant.
Yeah, I can see how gathering all that data ahead of time before you walk into that initial meeting could be really important in getting the sepsis program off on the right foot. I have a second question, and we have a lot of Project First Line viewers with us, and infection preventionists in particular. How can infection preventionists or IPs contribute or participate in a sepsis program? Pat or Dr. King, if you could let us know how you've incorporated them into your program.
Well, I think foundationally, the infection preventionists play a pivotal role in preventing and assisting and overseeing preventing hospital-acquired infections, right? So if you don't get an infection, you can't get septic. So that's really the biggest role they play. They're a part of our work. They're knowledgeable of the work and contribute to it, but that's where their contribution is the work they're doing to prevent an infection from happening in the first place.
And I can say when we look at our internal data, we know that there's a significant mortality cost and morbidity cost to hospital-acquired sepsis. Our outcomes data is significantly worse for that population versus present on arrival. And so in that setting, I think our infection preventionists are crucial in preventing all the poor outcomes that we see.
I'll just add here, that we will talk about this in some of our later webinars, but we do recommend that infection preventionists are part of that broader sepsis committee. Furthermore, I think in a lot of hospitals, the infection prevention program may be a little bit ahead in terms of organization compared to where a lot of sepsis programs are, and so folks in infection prevention may be able to communicate some of that institutional knowledge and that little bit of know-how about how to get the resources that you need to get your sepsis program where you need it to be.
Yeah, thanks for that. I think that they are often leaders in the hospital, and so bringing them into these programs can be really essential. Another question: how do you get leadership to promote accountability when it comes to following the sepsis bundle and documenting what CMS requires?
Yeah, so I think this is sort of a multifaceted question because it's accountability at what level, right? Is it at the individual level? Is it at the divisional or departmental level? And we've used our leaders at all of those levels. I think we have our sepsis coordinators as part of their responsibility is to review cases of sepsis, and our management of sepsis is close to real time as possible. So typically within 24 to 48 hours, and providing that direct feedback to those providers that were responsible for that patient's care. Typically they do this actually via email with a literal checklist of, this is what you did, this is what you didn't do. And those emails are all CC'd both to the division or departmental chairs as well as to hospital leadership. And along with those, we also send up quite a few what we call kudos around good sepsis care, right? That's what we really want to encourage good behavior. And so it's not infrequent that our leadership then reaches out to those providers as well, reinforcing our thanks. At the divisional or departmental level, there are different strategies that we are using. We have floated the idea about asking every department to come up with their own goals around sepsis management. I can tell you within the Division of Hospital Medicine, we always have a quality incentive that's tied to monetary bonuses. And so we have used sepsis and SEP1 compliance for hospital-acquired sepsis, which we know is more challenging to recognize. we've tied that to our quality incentive bonus. So, it's a group metric. It's not an individual metric, but it's a way to reinforce the importance of recognition and timely treatment.
So kind of in addition to that, part of accountability and ensuring that you're providing the evidence-based care is talking and reaching out to clinicians to find out what are some of the reasons why not, why did we not provide that care? What are some of the system issues and barriers that they're facing to give the timely and effective sepsis care? And then how can we change to make it easier for them to do the right thing, which I think is really important. And part of that feedback loop is we ask, was there any barriers or issues relating to you being able to provide this timely, effective care?
I really love the team approach that brings out in tying the metrics and bonuses to the entire department, and in really asking, what can we do as a system to help you as physicians improve the care of these patients? I think that's really important to, in a program, to be able to offer that sort of support. Okay, I'd like to close with a tough question here, because we recognize that facilities across the U.S. are extremely different in size, in scope. And so maybe I'll start with Dr. Prescott on this and then see what others think. But what resources are available for hospitals to tailor their sepsis program to their size and their location?
Yeah, no, I think that's a great question, and something that I think we tried to be pretty mindful of when we developed this guidance. I think at a very high level, the sort of scope of the sepsis program may be different. For example, in a very large hospital, the sepsis program is probably going to focus just on sepsis. But if you think about a much smaller hospital, that's probably not going to be feasible. So in a smaller setting, sepsis may be a core task of a larger committee that's focused on, patient safety or quality. Or if that hospital is part of a larger healthcare system, we have seen effectively that there can be health system level intervention such that a lot of the resources in terms of tracking or measuring or sort of developing these tools like care pathways and order sets can happen at a multi-hospital level, and then there's a champion at each of the sort of smaller sites. So there's sort of, I think, a lot of flexibility in terms of the operational structure of these, and sort of the best way is going to really depend on the sort of size and your affiliation with other hospitals, whether you're freestanding or whether you have other hospitals in your system, and you can leverage that sort of inclusion in a system to run your program.
Well, thank you all for those insights. I'd like to wrap up this amazing event with some key takeaways. Sepsis is a life-threatening syndrome of acute organ dysfunction secondary to infection. The source of that infection might be a urinary tract pathogen or a respiratory virus. And while the investigation into a source is ongoing, it's essential that the signs and symptoms of sepsis are recognized early, and that facilities have a unified approach to providing the supportive care a patient needs to survive. Remember, 1.7 million Americans will develop sepsis in a year, and 350,000 of them will end in a fatality. We have heard today about the new hospital sepsis program, Core Elements, and how facilities can use this resource to build a comprehensive program. Today, we focused on the leadership core element and the importance of that administrative commitment to dedicating the necessary human, financial, and information technology resources to a sepsis program. The clinical leaders, physicians and nurses running these programs, need protected time to do needs assessments and understand where their facilities' gaps are. They also need data analytics and information technology support, as well as a way to openly communicate the hospital sepsis metrics to build broad support across various disciplines. A strong commitment at the top will set the stage for how the sepsis program is built and received among the healthcare professionals at that hospital. Thank you again to our guests for sharing the core elements and providing us some examples of how to implement them in our own hospitals. As a reminder, a recording of this webinar will be available on this page shortly. We have drafted a PDF of information, websites, and links related to our discussion today. We hope you will find them helpful. You can locate this PDF in the top left corner above the video in the Resources tab. One last big thank you to our audience today for your interest and dedication to reducing the morbidity and mortality associated with sepsis. We know that recognizing and treating sepsis requires us all to be vigilant, and by working together and utilizing these core elements, we can keep our focus on better patient care and outcomes. We are excited to have you with us on this journey and as we embark on this 5-part series. In our next webinar, we will examine the core elements of accountability and multi-professional expertise. Join us as we explore the importance of appointing a leader responsible for program outcomes, the benefits of setting concrete program goals, and how to engage key partners throughout the organization. Part 3 will focus on action and how to implement the structures and practices that will help improve the identification of, management of, and recovery from sepsis. Part 4 will look at tracking and reporting, how to measure sepsis epidemiology, progress towards program goals, and identify ways to provide usable information to relevant partners. Finally, we will conclude our series looking at education and the impact of providing sepsis education to healthcare professionals during onboarding and annually. We look forward to answering more of your questions here and fostering this online community of learning. Thank you and have a great afternoon.